Hi, my name is Aaron Gerds, and I'm here with my good friend Lucia Masarova from ND Anderson, and here on behalf of VJ Hemoc to discuss the latest and greatest here at the ASH annual meeting for MPNs. Welcome.
Hey, thank you very much for having us around.
So a lot's been presented at this meeting. A lot of clinical trial results, preclinical data, even some new therapeutics. Did anything jump out at you as super exciting this meeting that you have not heard before?
That's a fantastic question because there's so many I haven't heard before.
It's hard to keep up with everything.
Yeah, it's hard to keep up with everything. Of course, we were awaiting the more updates of the phase 3 randomized trials with the add-on or combined the JAK inhibitors. A lot of good preclinical data, which I'm excited about. Interferon data. You've presented a great updates on the Momentum study, right? Talk about that one.
Yeah. Well, thank you for asking. So the Momentum study. So the Momentum study is a randomized prospective phase 3 trial competing momelotinib versus danazol in patients who had previous JAK inhibitor, who are also anemic and who are symptomatic with their myelofibrosis disease. And so it was the week 24 data where the primary outcome was assessed was already reported at prior Congress, but here we reported the next 24 weeks of therapy on study, the open label, post-crossover phase. So patients who were on momelotinib for the first 24 weeks or on danazol at that point were allowed to go on open label momelotinib. And kind of the key take-homes from the presentation were the responses that we saw at week 24 with the blinded portion of the study were maintained through week 48, whether we're talking transfusion independence, spleen volume response, symptom burden response. Additionally, kind of a curious thing, a few of the patients who were on momelotinib who weren't responders at week 24 ultimately became responders by week 48 in terms of symptom burden improvement. So that's kind of an intriguing thing because maybe we need to hang on to treatment a little bit longer before we can see the full effects. But most importantly, with the updated data, is we didn't see any new safety signals. And that's really key at assessing any new therapy.
I think that is a very important point with having more of the combinations in a frontline setting, where people will be doubting whether to choose upfront combination over more of the novel JAK inhibitors. They are not myelosuppressive, such as momelotinib, right?
Yeah, clearly that's going to be the key thing is we're going to take a look at single agent JAK inhibitor side effect profile versus how bad are the side effects with combination therapy, and do the added side effects from combination therapy are they outweighed or outstrip the positive results that we'll see in terms of spleen volume response and symptom burden improvement? I think ultimately at the end of the day for the combination therapies that are coming along, things like pelabresib and ruxolitinib, navitoclax and ruxolitinib, and many others, can we see more than just spleen volume responses? Can we see more than just symptom burden improvement? We got to do better by our patients, and I think that's what these really highly anticipated trials are going to hopefully show us.
I think that was a fantastic point. To definition of selective markers of these studies are really going to be the next work for us in the field, because we will have more and more drugs and we will have to answer the question, how do we sequence them? And how do we choose for what patient, what's going to be the benefiting? And then to that point, I think interesting data are surprising to me were the JAK2 allele burden with, for example, Ruxolitinib. That was not something I honestly expected. What do you think about that?
Yeah, I mean, that's always a tricky one, right? Because you can measure JAK2 allele burden in patients and it goes up and down without changes in therapy sometimes in some patients. And so it's always tough to say. Likewise, the bone marrow fibrosis abstract was truly interesting to me too, where there was no association between measured clinical outcome and changes in bone marrow fibrosis. So with all these kind of biomarkers, whether we're talking about allele burden, whether we're talking about bone marrow fibrosis, you wonder why do we check these things? Because if they're not fully correlating with clinical outcomes, what's the value? Sometimes I cynically think that we just check these things because we can. They're easy to measure, they're we know how to do it. But I think we need to, like you said, do further work, dig deeper, and get to whatever the true biomarkers are in order to get these early reads. Ultimately, we want to see people live longer and live better. But if we can predict that using a biomarker of some variety early on, I think that is key.
I think that's great. And you touched really well on the topic of the bone marrow fibrosis, where we have heard a very intriguing abstract from Stephen O and actually from MD Anderson as a lead author, student best abstract, about that the bone marrow changes do not matter. But then at the same time, we have heard update of the pelabresib combination with Ruxolitinib, showing that, well, okay, we have up to 20% of the patient that actually achieve complete resolution of the fibrosis. I think that is something interesting for us to be looking for and waiting for. Although we have a little bit contradictory results with that from interferons. Once we stop, the disease could still come back.
Truly, interferons are a biologic agent, right? So we have Intron is no longer on the market, but we still have pegylated interferon, and we have Ropeg interferon, and all those studies showing molecular remissions. I mean, intuition will tell you that that's not a bad thing. That is probably truly meaningful. The part that kind of really complements that is the French data on treatment interruption with interferons, where people can go and stay in remission, climatologic remission, without even treatment in those cases. And so I think it is biologically active and disease modifying. And every time we hear these abstracts and the new data comes out, it just kind of reconfirms that. The trick is, it doesn't happen for everybody, right? There are still plenty of patients who have persistent disease or allele burdens don't go down, or these kind of amazing remissions. And who are those people that really do, and how can we select for them and really apply this incredibly valuable therapy?
I think that's a fantastic point. We actually also have from our institution update on 15 years of pegylated interferon in ETBV, and we have seen some patients being technically cured. The JAK2 burden went away, although when we use more sensitive assay, it was still detectable at 0.something%. But we have patients who stop and never come back. But on the other hand, we have patients who has not achieved such a control and just rebounds right away. So what are those predictive tools that we can pick and choose and tell, hey, we're gonna do a couple years of interferon, you're gonna be cured, and that's it for you. Or those patients where hey, this is not the case, this is gonna come back right away, and then we'll need to come up with something better. Like the combination Ruxopeg study or
I mean, the big knock with interferons has always been toxicity, right? Patients can't handle, can't tolerate interferons. And that's true to a certain degree, with the older versions of interferon and the intense dosing that used to be done. But the way we can handle nimbly interferons now, especially with the newer things like Ropeg interferon that has a potentially better side effect profile, I'm glad that we were revisiting this. And case in point, every ASH we come here, we hear more interferon studies that kind of reconfirm that idea. And Ruxopeg is a great example. You'd say, okay, we take Rux, we combine it with interferon, which is pretty toxic. This is going to be, people aren't going to do well on it, but they actually did. And to me, the responses are, of course, intriguing, and I really like to see those, but the tolerability of the combination really stood out to me as well.
I think that was impressive. Pegylated interferon, 135 mic per week, is a dose I would never use as a single agent, because it would be quite toxic.
It's pretty toxic.
And with the Ruxolitinib, there was pretty much almost non-discontinuation, like 2%.
I was pretty surprised to see that. If you would have had me guess before the study was done, I would say most people would have been on, like, say, 45 micrograms of
that was my bet as well.
Or maybe a couple patients will get up to 90, but I was pretty impressed with how big the doses could get.
Yeah, that was...
I think they think that's going to only deepen your biologic response, I think, if you can get more in folks safely.
Yeah. What are some of the novel agents that you're interested in?
Yeah, certainly the way I kind of organize them in my mind is we had the last wave, which are all the new JAK inhibitors, the pacritinibs, the fedratinibs, and the momelotinibs. And the next big wave are going to be these combination therapies. So like I mentioned, pelabresib, navitoclax, parsaclisib, and all the other combination therapies. And the next wave after that is going to be stuff that's truly innovative. We heard the plenary abstract this year on monoclonal antibodies directed against calreticulin-mutated disease.
That was fascinating.
I mean, it's fascinating, right? So if you have a monoclonal that can affect change, it's really well tolerated, has a great side effect profile, then, as oncologists, we like to put things together. So we're going to do it in combination. And then, building off that, if it truly does target that, could we do bispecific antibodies and use the immune system to kill these things? Can we come up with, some sort of engineered T cells or BiTEs? Yep. And so really, I think that's the future, right? So that's going to be the next wave after the next wave. And that was really exciting for me to see.
I think that was exciting because here we are actually going after the clone. We are not only, doing something for spleen and symptoms, as you elaborated at the beginning. We have to do better, go after the disease. So they showed that actually it does deplete the malignant clone. So probably next step would be to go after JAK2 mutated cells.
Yeah. Simple next step.
Yeah.
Yeah, and likewise, So we're opening up a study at our center looking at a vaccine trial. And so the protein for the vaccine does include JAK2, calreticulin, NPL, all three mutations, and then given a ipilimumab boost to kind of enhance the immune response. And so, yeah, I mean, if we can harness, immunotherapies, even antibody therapies to really kind of go after those clones and eliminate them, to me, the biggest gains are going to be in people who actually have lower risk disease. High risk disease is so molecularly complex, it advances so quickly. I worry that some of these therapies may not be as effective, probably augmentative, but not transformative. But think about someone with kind of a high risk ET that could turn into myelofibrosis in a few years. But if you turn back the clock 15 years, that could be a real huge win for that individual. So to me, that's really exciting because we don't have a lot of therapies for lower risk myelofibrosis and ET and PV because, quite frankly, people do so well for so long. But if we could really turn back the clock for those folks, it could be a huge win.
Yeah, that's really very exciting to me. What about the TP53? I think that's always spanning lots of debates as emerging TP53 clone if we actually use the key negative regulators like MDM2 inhibitors, which I think there are a couple data, even on the combination with the PPM1D, which was very interesting as a first kind of put in to see some efficacy and some safety. That was something I was really interested in, but we'll probably have to follow more on the possible emerging TP53 clones. In that setting, I'm a little bit more anxious about how it's going to play in disease such a benign as some of these diseases are.
Yeah.
So.
And you can think of some patients that who've had P53 clones, and you're like, I don't know what to do, and you kind of sit on and nothing happens, right? It is almost like a ticking time bomb. But because if they progress, it's just so hard to treat. Refractory to chemotherapy is more likely to relapse. Transplant outcomes are worse. They're not zero. They're not horrible. It's not feudalistic, but it's not great. And so, I think likewise, therapeutic approaches to attack P53 mutated disease is desperately needed. Not just in MPNs, but I would say all malignancy. I mean, this P53's mutations being bad is a universal truth in oncology medicine. And so I think going after that could not only benefit patients with myelofibrosis and MPNs, but all oncologic patients in general.
Yeah, there's been lots of data about the CD47's macrophages. Has not translated to myeloproliferative neoplasm yet, but maybe we will see that sometimes in our lives to go after those clones and see how they're going to play out.
Yeah, absolutely.
But I haven't seen lots of data about accelerated emblastic phases. Those are really the bottlenecks that we are facing, that we don't really have anything for our patients here.
No, nothing. I mean, we're still doing things like Ruxolitinib and hypomethylation agent in combination in our clinics, maybe Azavan, and that's about it. I mean, there's not really anything moving forward. Starting to use targeted therapies, right? So the MPNRC 119 study looking at IDH2 inhibition, but that's not really new in the AML world, if you will. So I think better ways to attack accelerated blast phase disease is certainly a critical unmet need.
Completely agree.
Well, thank you so much for spending a little time with me chatting about the updates in MPN world here at the 2020 ASH meeting. And I look forward to seeing you again over the course of the year and reconvening in 1 year to talk about what else is new.
Oh, thanks very much. It's been a really exciting year. We thank the Immuno-Oncology for inviting us and for having us part of this lovely discussion.
Thank you very much.
Thanks much.